Thank you for joining us for the Healthy Transitions Colorado August 2015 webinar. My name is Courtney Bentrott with the Center for Improving Value in Healthcare, and I'm very happy to be here with you today as we talk about enhanced community building in the reduction of preventable readmissions. Healthy Transitions Colorado is run by operating partners, the Colorado Healthcare Association, Telegen, the Colorado Hospital Association, the Colorado Medical Society, the Colorado Rural Health Center, the Colorado Behavioral Health Council, and Health Teamworks, and is managed by the Center for Improving Value in Healthcare. Healthy Transitions Colorado is a collaborative effort focused on aligning and accelerating existing efforts to improve transitions of care for Coloradans. Our guiding principle is that by breaking down the silos of healthcare, we can foster true community care coordination across facilities, specialties, and practices. HTC coordinates the tools, resources, and efforts of many partners across the state. We want to keep Coloradans healthy so they can enjoy more of what our beautiful state has to offer. If you haven't already done so, we'd like to invite you to become one of our community partners and take the pledge to improve patient care transitions. To take the pledge and learn more about HTC, visit our website at www.healthytransitionscolorado.org. I have just a couple things before we get started. The phone lines have been muted and will remain so throughout the webinar. We'll be using the chat feature available in the lower left-hand corner of your screen to field questions and allow you to make comments on the discussion. Questions posed to the presenter will be answered during the Q&A session after the presentation. This webinar is being recorded and will be posted to the HTC site, so you may access this information again at any time without cost. I would like to quickly mention our upcoming Learning Series Symposium, Nurturing Community Collaboration, on October 16th, where the focus will be on enhancing the network of care via communication between community partners throughout the care continuum. Registration is now open at www.healthytransitionscolorado.org. Now, I'd like to introduce our guest speakers, Michelle Bowman-Whitmore and Renita Henson. Michelle is the Director of Integrative Medicine and Age-Well Transitions of Care. Michelle is a board-certified gerontological nurse and a licensed acupuncturist. Michelle was the visionary creator of two award-winning Longmont United Hospital departments, Age-Well, which has evolved into the hospital's Population Health Management Transitions of Care Department, and the Health Center of Integrated Therapies, which provides acupuncture, massage therapy, nutrition, herbal counseling, and more to 10,000 plus community members annually. Renita is the Senior Wellness Nurse and Transitions of Care Coordinator at Longmont United Hospital, as well as Systems of Care Initiative Care Transitions Coaching Coordinator. Renita began developing the Transitions of Care program for Longmont in April 2011. She came to Longmont following 15 years of home care experience and many years of hospital nursing practice. She is also the Care Transitions Coach for multiple hospitals and the Accountable Care Organization in Northern Colorado. Please welcome Michelle and Renita. Michelle and Renita, I will now hand the presentation over to you.
Thank you, Courtney. Can you hear me okay?
Yes.
Okay, great. So it's an honor to be here today with all of you from Longmont United Hospital. I'm really excited to also announce to you, as of last Friday, a week ago, we are the 16th hospital to join the Centura Health System. So it's official. We are a Centura partner, and we're excited because we get to share some of our innovative transitions programs with a larger group of hospital-based system. So today we're going to talk about community engagement, and we're very excited to share with you some of the programs we've been doing to engage our community. We all know that healthcare is in a very big transformational phase. We still have some parts that are fee-for-service, and we have value-based purchasing in place in our hospitals where we're paying penalties for those patients and that are readmitted, and we all know we have to move towards population health management. And I think we can all admit that we have one foot on the dock still and one foot on the boat, and it's a little bit of an unstable time as we're trying to figure this all out. So we're going to share with you some of the strategies we've tried. We believe that transitions of care is really about transforming healthcare, because we really are in a culture shift right now in our form of healthcare in the United States. And it's exciting to be a part of this beautiful transformation that's happening with our system. So at this point in time, I'm going to have Renita. She's the beautiful one on the right of the screen. She's one of our master coaches that's working in our transitions program that Courtney introduced to you. And she's going to come and tell you a little bit about the history of our program, because we feel like the history of our program is vital for you to understand, so you can see how we got to where we're at today. Because moving from a very pillared system that we're all in to a real collaborative system takes a lot of time and effort. So here's Renita.
Hi everyone, thank you so much for being here with us today on this webinar. I really wanted to talk about where we came from, because it's a part of how we figure out what we've changed and where we're going and why it worked or why it didn't work. As I look back over what LUH had to offer, I really saw that we had all these individual little groups. We had care coordination doing their beautiful work. We had social work doing their beautiful work. At Longmont United, they brought in a palliative program to try to address those end-of-life care issues that no one really knows what to do with it, because in medicine, you know, it's our job to keep people alive and going. So what do you do with those that aren't falling into that wonderful little picture for us? And then Michelle was offered an opportunity in April of 2011 or around that time to put together a grant project looking at transitions and developing a transitions program for the hospital. This was in collaboration with 5 other hospitals nationwide, and I'm really glad she decided to do it, because that's how I got to come and play with this team and start working on what we were going. And Michelle and I did a lot of studying and research. We really liked what Dr. Coleman was doing. Back in those days, he was using the volunteer system. So we chose to follow in those footsteps and look at the volunteer program. We will talk more and more about the volunteers as I move forward, but just created a program utilizing volunteers, following that basic coaching model of meeting the patient in the hospital, following them to home. And as part of the grant, we used the PAM in those days to really look at what patient activation was and how patient activation moved forward as we took the time to work with people. In November of 2011, CHA came up with the grant to run the Project Red programming, and we had another hospital nurse. Her name is Lisa, and she was the one assigned to take on that grant, and she created what we called our inpatient program, looking at transitions, working with the medication review, the physician follow-up, same things that we're following in Dr. Coleman's program, but really working with those on the people while they're still in the hospital and on the inpatient side. As you can see, that inpatient transitions spread out a little bit. Longmont made a choice to choose a follow-up phone call, automated phone call system. It was originally Cypher. It became Solar, and that's the automated calls that go out within 24, 48, 72 hours after discharge, and then it repeats at certain intervals with certain diagnoses, especially the heart failure patients. The other thing that changed was we realized that our nurse practitioners would be better served working with our patients in the hospital, really focusing on their advanced illness management and how to help people look at those advanced illnesses that are not responding to treatment and not going to get better and not going to get well. And palliative itself became a referral program, and the nurse practitioners started seeing the patients while they're in the hospital with us. Moving forward within that system, we realized that we needed to drop some of those silos. Transitions of care combined inpatient and outpatient. Jen and I are now one team. We have a third nurse, her name is Lee, that was doing the Solar calls. She's out on a leave for right now, so Jen and Michelle and I are handling that part of the program. But bringing all of transitions together within one group of people except we can't do it by ourselves, and we know that. We have to have our nurse practitioners, and we have to have all of the other services. So the group met together, came up with this beautiful title called Continuum of Care, and the Continuum of Care is the nurse practitioners, which we call AIM, Transitions, Care Coordination, Social Work, Chaplain, Physical Medicine, Dietary Pharmacy, HCIT, and the LCHM program. So as you can see in this beautiful circle of care around our patient and family and their partners, that we have all of these pieces that are touching not only each other but touching back to our patients. And it really takes all of us working together and working in conjunction in order to make an impact on the patient. In the meantime, while we've been doing all of those wonderful things and working on our inside of the wall programs, in 2012, Boulder County came up with a Care Transitions Collaborative. It's county-wide, including most of the services that touch healthcare. And Jen and I are both current leaders on that. We have a 7-member leadership team that runs the collaborative, and Jen and I are both members on that. But as the county has chosen this year to work with the home cares, and we're all doing our little individual groups within the home care system to make that a smoother transition for our patients, I really wanted to go back a step and pick up with our nursing facilities, because at LUH we still have a high number of readmissions coming back into the hospital from our skilled nursing facilities. Interestingly enough, at the very first meeting that we sat down face-to-face, we really realized that the number one issue was what was happening when those patients hit the emergency room. So we got one of our emergency room physicians. She joined our team, and we have been working for a little over a year now on how to improve those transfers from the nursing home to the ED. How do we prevent that ED visit from being an admission, and how do we get it back? One of the beautiful things that has come out of this is we actually have physicians from the nursing homes that call and talk to our physicians in the ED, and they tell them what's going on and why they're concerned and what they're looking for and what they feel that they want and why they made that choice. We don't have it perfect. We don't have it all down pat. We still don't do it 100% of the time, but when it happens, it's a really beautiful thing, and the physicians really feel that they're participating in what's going on with that patient. So it's really been fun. Our ED physician that's on our team, Dr. Hall, is also in charge of the fire department and paramedics. And what we have now done is included within our meeting one of the firemen, and he is helping us realize where the EMS system has their blocks and how they have to focus and answer to calls and what they are required, and then they're starting to understand what's needed on the nursing home side and on the hospital side. So we're expanding then further out in our next project, which is coming up in the early part of September, is the doctor from the emergency room, myself, and the person from the fire department. We are going out to all the assisted livings in the Longmont area to say, what are your rules? What are your regulations? Where do you keep your most form? If your most form says that your patient doesn't need to be transferred to the hospital and they don't want to have CPR, why are you calling the fire department, and what is it that you're really wanting us to do? So that we can support each other and really work together within that system. So it is continuing on a progress of development, and I'm really, really excited. I can't wait to get this meeting coming up in September to see where we go with this and the new relationships that are built and how that goes forward. So you can see our original circle has grown immensely. We have so many other circles that are added to our team. In the Boulder County Collaborative, Angie from the Boulder Clinics made this beautiful mandala, and it has these pieces of line that go from person to person and crosses and crosses, and it's gorgeous. And I was afraid to try to do it on the slide, or all you're going to see is lines and you won't be able to see any of the words. But we really do have a lot of links out in our community that are now working with us as a hospital to really focus on that patient and how we best serve that patient and how we best help that patient and their families or their partners find what it is that they need in order for them to be able to reach their goals. I told you earlier about our care partners. This is how I'm doing it. This is our kind of what we call our outpatient program in addition to the things going on in the collaborative. You can see my original team back in 2011. They're all seniors. The first original group were all recruited by Michelle. They're all patients, former patients of the hospital and patients of the Health Center for Integrated Therapies. And the group has continued to evolve and grow. I had one person retire again this week, and I had another person come in the last 2 weeks. So it's really hard to keep an up-to-date picture. But as I said before, now, since we started the program, I've actually officially become a Coleman coach through the program, and I have trained everyone on how to really listen to what it is that your patient wants, listen to where is their goal, where do they want to go, and how do they want to get there. We still follow the basic program of a hospital visit, a home visit, and follow-up phone calls using the pillars of care. And as you'll see in the next few slides, we've actually taken some liberties. So to also justify one of the things I wanted to say is we call ourselves a hybrid. We're not a true care transitions follower. We have hybrided to meet our needs. But for the most part, we're pretty honest to what Dr. Coleman originally set up and designed.
So here are the pillars. The first 4 pillars are the traditional pillars followed in the care transitions model of Eric Coleman at the University Health System. We're finding with our population base, we really, really needed to add some more pillars because we've seen some gaps where care falls down and where readmission happens. So our primary goal, and what I want you to hear throughout this presentation, and what we've really strived very, very hard to do, is identify patient goals. We are going to, anytime we can, we're going to teach and coach and encourage all of our partners to get that patient's goals. I think we're all from a system, I'm a nurse, Renita's a nurse, where we're so used to following physician orders. And so really the directives that we embark upon when we treat our patients are usually physician-driven goals or nursing goals. And we've really got to get to the place, if we want engaged and activated, confident and knowledgeable patients, no matter what their disease process is, we have to get them included in their care. So it's how we're going to change and create a new culture of healthcare. And it's vitally important. So you're going to see throughout this presentation how we bring patient goals into the care that is given. And very vital. This I wanted to throw in because this is a telemetry care map, inpatient care map. And when we do the follow-up phone calls on the outpatient side, we commonly go in and look at the care map and see if we can find some patient goals. What we usually find is some beautiful nursing goals. Our nurses are so good at writing nursing goals. And usually there's a line from the nursing goals on the left written all the way across through patient goals and agreed goals to the interventions. Very, very, very rarely do we see patient goals. And if we do see them, they're usually related to a nursing goal. So we've really got a lot of work to do to start to really embrace this. What we're doing at Longmont United Hospital to really help dive into goals and more relational-based medicine is we just were interviewed by the Schwartz Center and Harvard Business School. And we were picked as a best practice throughout the United States for our questions we ask on admission. They're called our plane tree questions. We are a designated plane tree hospital. And the questions are on the right. These questions move us into a deeper relationship beyond a diagnosis with our patients. as you'll see, how does your past experience in the hospital affect how you're feeling right now? What would you like me to know about your daily routine at home that may help and improve your care? What is there that you want us to know that might make your hospital experience better and less stressful? So you're going to hear how we dive in to get to know the patient better is key to changing the culture of care. So this is the form we use, and yes, you will all be getting copies of these slides. I think Courtney can share that at the end when these will be coming out. This is actually our Continuum of Care team. This is the working document and form that we use when we meet weekly. So we definitely do Continuum of Care case where we look at patient-centered case studies. And what you'll notice always is important is patient name and age, and we also need to know who their primary care physician is. Because on the inpatient side, you all know we are dealing with mainly hospitalists. So we don't often ask who the primary care is. We want to know that. We think that's important for continuum. We want to know the diagnosis, but you'll see on the third line, patient goals. We also think it's important to know where they're at with advanced directives. You know there's communities like Gunderson back east who have 100% of their community have their advanced directive forms. We've got some big initiatives in place in Boulder County that we're trying to move this process forward also. So advanced directives, we'll talk more about that and what we're doing. This is all about community engagement. We also know where the patient, want to know where the patient is on the spectrum of chronic illness. Are they stable or are they advancing? We also want to know how activated they are. Are they activated and engaged in changing any of their healthcare patterns? If they're not, we actually structure their coaching to a different level because you can't coach everyone at the same level. Everyone's at a different level because that means we're listening to them as individuals. So you can't teach all CHF patients the same way. You can't teach all COPD patients the same way. We also, you'll see, address more than just their physical issues. They need to be addressed at a psychological, social, and spiritual culture level too, because sometimes those are the primary issues that are affecting their physical health. We need expert collaboration. Who is needed on this case? Who's not involved? And who is in charge and the communicator? Who's going to get back to us and let us know what's happening? And at the bottom, you can see what our recommendations are and who is going to provide the first and second line of care in the community. Basically, what are our primary goals? Based on the patient goals, who's going to do them? And so we're all on the same page. This is a vital document, and we use this at every one of our meetings. So it wouldn't be fair to me or all of you to talk about patient-centered care if we really didn't talk about a patient. So we asked Bill if he would let us share his patient-centered story. Meet Bill, one of my favorite people on the planet. The pillars that we need to work with on Bill are his accountability, movement, and nutrition. Those are two new pillars we've added to the 4 pillars previously discussed. So Bill, this is a picture of his whiteboard. This was about 3 years ago when we were just piloting our whiteboards on the inpatient side. Bill, as you'll see when I show you his background here in a moment, is a frequent flyer to our hospital, or was a frequent flyer to our hospital. And what we found out when we started looking at what the goals were, as you'll see in the left bottom corner, they're nursing goals. Walk 3 times, and when I asked Bill how much he would like to walk, he said 50 times. But he said, Michelle, you'll see that X in the small right-hand corner, it says high fall risk. And he said, even worse than that, they have me on an alarm. He goes, I made the stupid mistake of telling them that I fell when I was a patient at Boulder Community after a surgery because I wasn't tolerating the pain medicine. And he said, so now they won't let me walk but 4 times a day. Well, so anyhow, interesting. I said, Bill, would you agree to be my own personal patient-centered care person? Will you be my guy that I follow? And he agreed to do that. So here's a little bit more about Bill. Bill has been in our hospital since 1985 over 300 times. I quit literally counting at 300. He has had 33 surgeries. He's got a very serious immune deficiency. He is a celiac sprue, gluten intolerant. He was the past president of the Celiac Sprue Association of America, and he speaks nationally. He's an amazingly brilliant man. He also has trained 25,000 dogs in our community. He's the canine whisperer. He also was a high school teacher in our community, very well loved. Chronic pain like you would not believe, and is on more than 20 medications, including methadone, which I am not happy about when we use that for elderly because it causes so many other side effects. So we're working very hard to get him weaned off of his methadone. He utilizes our services at our Health Center of Integrated Therapies at least once a month for massage because that helps with his pain management. And he feels, this is his words, that his visits to our Integrative Medicine Center are more valuable than any of his physician appointments. Now, we know that's not true. His physician appointments are vital. But what he gets here that he probably doesn't get much of at his multiple specialist visits is he gets a lot of relational care. And so we've been meeting with him, talking with him, and because of the work we're doing with him, which is, you're going to hear in a minute, is not real rocket science. He hasn't been in the hospital since November of 2013. So this coming November, it'll be 2 years. That is amazing for him. What we found that was the most impactful way to prevent his readmissions was one day I asked, Bill, I'm just so confused about why you keep coming in. You keep coming in with pneumonia. You've got all these immune problems. My friend, what is going on with your diet that is causing all of this? I know you're gluten intolerant, but there has to be something else that you're doing that's not allowing your body to heal sufficiently. And he got really, 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 really quiet. And he said, no one's ever asked me that. No one, Michelle. And he said, I've never told anyone this. This is my biggest secret, but I have an addiction. And I'm thinking alcohol. I'm thinking, something. And he said, and you're going to laugh at this, but he said, I am addicted to jelly beans. So you may all be laughing at this point in time, but he would not leave his house unless his pocket was full of jelly beans. He had a big bag of jelly beans in his car. Did you know, he taught me, that you can buy defective jelly beans. They're called jelly flops, like belly flops, jelly flops, and they're the jelly beans that are stuck together. So we looked at the ingredients. It's a lot of sugar, high fructose corn syrup, and a lot of dye. It took us 7 months to get him off of his jelly beans, but he has not had any more pneumonia. He has not had any more infectious issues that he was having that brought him into our hospital. Now you know why I think it's important to include on our pillars nutrition. And we're not just talking about cholesterol. We're not just talking about some of those classical registered dietitian types of things that we discuss. Those are vital, but we've got to dig deeper, and it takes a relationship to do that. So you already heard me talk about his issues with falling and how it caused him to be more immobile while he's in the hospital. One of the big initiatives our hospital is taking on is early mobility, and it's starting in our ICU. I've just sent some clips here, some screenshots of some of the evidence-based papers that we're sharing with all of our nurses. These are actually part of our policy and procedure for our early mobility program. I am so passionate about movement that our transitions of care team hired our own exercise specialist and our transitions mover. Her name is Tammy. She's actually here in the room with us. We're very proud of her. She's a Pilates instructor, and she's also a Reiki master. Her job is to go in before people are discharged to evaluate their movement status. Do you know if they haven't been seeing PT, physical medicine, during their hospital stay because they may not have a need for PT, even though they are functionally not moving well? If there is not a skill needed, they won't see physical medicine. So Tammy goes in and assesses them. She does a evidence-based scale, mobility scale rating, and we then have a documented place where they're at when they're discharged. If needed, she goes into their home, reevaluates them, she gets them moving, and connects them to the appropriate patient goal-driven programs for movement in our community. So that may be back to our cardiopulmonary exercise class, that may be to a Nordic walking class. It may be a one-on-one program that we can set up in their home. But Tammy, it's taken us about a year to get this done. She's been through a competency training. This is a policy and procedure that we've initiated, and she does all of her training with our physical therapists who are excited, very supportive about this program. Now, this slide is a lot of mumbo jumbo. Please excuse the copy. I'm very excited about it, and I had to put it up here because this article was just sent to me by our CEO, Mitch Carson, about 2 weeks ago. At the bottom, you'll see it's the evolution of alternative medicine. Now, this CEO of ours comes from Muncie, Indiana, a hospital system there that had no idea what even alternative or integrative medicine is about. So to get this journal article from him, which he sent to all the leadership, was a big, big day for me, because what he's saying and what this article says is that integrative medicine, the National Center for Complementary and Integrative Medicine is funded by the National Institute of Health, which it speaks of in this article. But what it showed me was he was supportive of the evolution as being part of population health management. So I'm going to get into this with you a little bit now. Why I love this copy, and you'll be able to read this more, but this article was talking about a physician who attended their American Academy of Family Physicians meeting, and what they said at this meeting is what is really the driving message of this webinar to all of you. Most speakers in this conference that this family practice physician went to said most speakers led the relationships they have with their patients, what a privilege it was to serve people in a relational way. Family doctors know their patients. We're more likely to garner meaningful information about their histories, what their jobs are like, and what they're exposed to, and how their family relationship are. These are key factors in health outcomes. It's exactly the situation I just shared with you about Bill. When I dove in and got to know him better and built a relationship with him, I got to know what was really impacting his health. I love that we're moving our culture shift in healthcare towards this relational-based medicine. It's a big, strong strategy at our hospital. We're doing a lot of it. My relationship with Bill was so strong. He was one of the 5 families that lost his home in the tornado that hit up here. He lost his tornado about 2 weeks before I got married. I just got married in June to my high school sweetheart. And about 2 weeks after the tornado, Bill came in for his regular appointment with me to talk about how he was doing, his accountability. And he said, Michelle, I understand you don't have anyone to walk with you in your wedding. Would you please allow me that opportunity? Bill walked with me and gave me away at my wedding. So it felt right, and it was a wonderful opportunity for both of us. So the way we're continuing on with stories and relational-based healthcare in our organization is we now have a program called Story Catchers. And on the far right is the co-chair of our Patient and Family Advisory Council. Longmont has probably one of the oldest Patient and Family Advisory Councils in the state of Colorado. This is an important topic for all of you because Colorado Hospital Association has an initiative that they would like all Colorado hospitals to have Patient and Family Advisory Councils. So we were invited to a recent presentation in the spring on PFAC. So you're going to hear PFAC, PFAC, PFAC. That stands for Patient Family Advisory Council. On the far, I am the co-chair, director of that PFAC at our hospital, along with June Berlinger on the right. June is a retired hospice nurse, hospice director, and she also ran a large women's clinic in a Florida hospital system. She retired here in Longmont, and she has been the best volunteer catch we have had in so long, even though we have many wonderful volunteers. She has recruited a group of now 6 volunteers. They go in, her and 2 others go in at end of life, sit with the family, and they catch the family story. Usually they go in, and the environment in the room is very subdued. It's very tranquil. When she starts engaging in stories, it turns into more of a there's a lot of laughter, there's fun, there's tears, there's sharing. She gathers the story, she goes and writes the story, she brings it back. If they want it edited, she edits it, and then they come back and read it. They read it aloud with everyone in the room that can be there. What we have found is when we do this at end of life, we have seen that our patients transition and pass sooner than any of us have expected. The last 6 stories we've caught at end of life, that patient has transitioned between 1 and 3 hours after their story was shared. Why is that? Because relationships have been healed by that laughter, that story sharing, and by everyone gathering together. This is a profound program and one of the best things we've ever done at our hospital. We also do what we call short stories, where we go in and just catch really short stories and put those on the chart to help build knowing that patient more than just their diagnosis.
And with the short stories, another piece that a couple of the ladies have started doing is going out to our local nursing homes, and they get those stories, and then that story of who that person is actually travels with them if they need to come from one of the nursing facilities back to the hospital. So we don't know that it's just a person with some disease process coming into us. We actually have their story coming in back to the hospital with them. So I think that's a cool addition too.
I've had home care say, hey, we've had your patient's story, we read it and it changed the way we gave their home care visits. So we know knowing a patient deeper changes care. Here's a picture of our Patient and Family Advisory Council. We have 16 members right now, 11 are community and family members, and 5 are hospital staff. This is a picture that was just taken last week. 2 of our current members are at the end of their life. So we do have patients that are in hospice that sit on our Patient and Family Advisory Council. Very helpful group. I just did a big presentation yesterday on this for our hospital. Let's see. This is our Health Center of Integrated Therapies. It was started from our Patient and Family Advisory Council back in 1993. Our community members, our wise ones we call them, they said we would like to see our hospital at Longmont swim upstream and help keep us well. This was population health management 23 years ago. So we listened to them, and this group of community elders, which many indigenous cultures listen to their elders in a much better way than we do. But we listened to this group. They did a fundraiser, and 74 of them sent me to China. I went over 3,000 to 4,000 miles in China studying their culture with the Chinese Commission on Aging and the American Society on Aging. And we now have a large integrative hospital-based program, and here are some of our services. Our current chief physician advisor is one of our emergency department doctors. We get direct referrals now of frequently readmitted patients. Instead of admitting them to the hospital, they send them down here for the same day care that we can do here. Maybe it's for PTSD, managing their anxiety. It can be for chronic pain conditions. We have seen many people come down here homeless. And with our networking that we do with our paramedicine program, which you're going to hear about shortly, sometimes our paramedics will bring those patients here for that visit. So we are seeing a link between integrative medicine and prevention of readmissions. We do have 1 primary center and 4 branch sites, and we also offer these services within our hospital based on, in the hospital we have to have physician order, but we do have some standing orders in some of our departments. Very exciting program. And remember that form I showed you about the continuum of care, how we believe that the spiritual and cultural values of our patients are definitely important. 4 years ago in 2011, a community member brought forth a teacher that he had brought over from India and said, Michelle, I am giving this teacher's beautiful talent as a gift to the community and the hospital. So this is the most unique gift we've ever received. But for the last 3 to 4 years, we've had the wonderful services of a monk from India who lived 26 years in an ashram. He teaches twice a week at our hospital and in our community. He does classes on Tuesday and then meditation on Thursday. He rounds on patients that want to see him. He does community presentations, and he really brings a sense of peace and equanimity in with our patients that are suffering from PTSD. He's worked with a lot of homeless in India, so homeless to him is just a beautiful, beautiful opportunity and a beautiful gift. So Swami has been one of our greatest gifts And if you ever would like him to come and speak at your hospital, I strongly encourage it. He's a very articulate man and a great, great speaker. So I want to have Renita come back, our wonderful wellness coach, our nursing coach, and talk to you a little bit about our paramedicine program.
The paramedicine program started a year ago, and they have another year left on their grant to really reach out to the community and fill the unmet needs and the gaps that are happening within healthcare. We have, great programs that are available for seniors. We have great programs for the kids, but there seems to be that gap group in the middle that nobody has all the services and the programs for. However, it's not just limited to that. We use the paramedics for a lot of our seniors also, because they can go out and sit down with them one-on-one in their home for an hour or 2 hours or whatever it takes to really reach what's going on with that person and what's happening. The program targets for the paramedicine program are the CHF, COPD, and diabetes. One of the paramedics himself is a type 1 diabetes, and it's watching him work with patients and hearing the stories behind how he can just tap in and get down to the basics of what's going on with those patients and help them be able to start managing and getting their diabetes under control. It's just amazing. I love watching it happen. And what I really love about this program, as you can see around this table at one of our meetings, we have so many programs that are providing care. We have the Salud Clinic. We have the Hope Light Clinic, which is a clinic that is for the uninsured and underinsured. We have our senior center with their resource specialists. We have our nurse practitioner. You see me there. The paramedics are kind of up at the top of the screen with the program coordinators. And actually a couple of my nursing students that I have through the hospital program are coming, and they're learning more about what happens in the community. It takes the whole community to make these cares happen and happen smoothly. And the one thing is we've convinced them to use the same continuum form that we use, so it stays goal-focused. It really stays on what is it that the patients want, what do the patients need, and how do we help them be successful in their health care. We partnered up with our Longmont Senior Center 15 years ago through Michelle Waite, who is the director for the City of Longmont Senior Services, wanted to include wellness in all of the other phenomenal level of services that they offer. I don't know if any of you know, but we kind of are a nationally known senior center. People come here from all over because of the things that we are doing with our seniors here. But Michelle had the wisdom to know that we needed to add wellness as one of the components and one of the parts. So I have a weekly clinic on Mondays where it's just an open clinic. People can come in. We do a quick check on where they're at in their wellness and where they're going. If they need longer time, I do one-on-one coaching with them about what their wellness plan is and what they're going to do. The other thing we do with the Senior Center is we do a lot of community teaching. We have programs on a monthly or a twice-monthly basis that we're bringing health information to the people in the community and help them know. So the next several slides are looking very busy, so don't spend time right now if you want to reading them, because we're just going to highlight them and you'll be able to get them coming up. So these are some of the classes that we started teaching.
We started these because we said, how can we really start to address population health management from a community perspective? We decided our partnership with the Senior Center was so vital, let's start educating there. So what we decided to do was educate our community members on how to navigate the healthcare system. I've included all the text in there so you can see who comes to this. We had, sorry for you Telgen people that are on here, these were some programs we started back when they were still the Colorado Foundation for Medical Care, but we brought in people to talk about accessing health care when you're well. How do you do it? The next one is, how do you access health care in an emergency situation? We want people how to know where to access care the best and how to access it correctly. So we brought in ED docs, urgent care docs. This one's on accessing health care in the hospital. What do you need to know if you're coming in the hospital? Should you have a checklist? What questions should you be asking? We want people to be good health care consumers. The next one is, shouldn't you know the terms? Because as we all know, we've ticked off a lot of our Medicare patients when we went to the observation status and they had to pay for their meds. They need to know about that. So we now have, we educate them before they even come in the hospital. We also have advanced directive classes. They actually pay to come to these. We've been doing these for 15 years. We expose them to the MOST form, CPR directives. We expose them to all the different forms. We actually coach. We have at least 15 to 20 people that come to every class. We do this monthly, and we've been doing this for 15 years. We also are a part of the countywide Conversation Project. We have been deemed a conversation-ready county. If you don't know about the Conversation Project, you must know about it. Here is the link to the website. This is a very vital project. They have conversation-ready starter kits to help people start the conversation to get their end-of-life documents going. I am so proud of our senior center. We do death cafes. We do death over dinner. We are really, really embracing end-of-life planning and talking about death, because the moral of the story is we're all going to go there. We're all going to die, and we need to get out of our cultural fear of dying. So very quickly, let's end this presentation so you can all ask some questions. Let's get real about all of this. We still have a patient population base that many people like being in the hospital. They love having a break. Caregivers sometimes love having their loved one in the hospital. Some patients don't want help. We see it every day. We still have a system that promotes dependency. We still have staff that are helping make people more dependent instead of coaching them. We need to shift from teaching to coaching. We still have physician practices that are still based on the old model of care, where they see patients in 2 or 3 minutes and don't get to hear about those relational types of issues that really are keeping them from being well. We also need to focus our resources from the inpatient side, because that level of care we give there is so short, to the outpatient side, because that's where we can make the biggest impact. And we also know, at the last management meeting I went to at our hospital, our outpatient revenues now exceed our inpatient revenues. That's going to drive care. We cannot prevent all the readmissions, and that's why we still have hospitals. So thank goodness we'll still have jobs. And we still need to figure out who's coordinating care. We always think it's the primary care physician, and in some accountable care organizations that is the case, but that's not always happening. And we think who should be coordinating care is the patient or their designated learner, which is not always their family. So we should not end this presentation if it wouldn't, we need to end on the voice of a patient. And we decided that Bill, we asked him, what do you all want to know? And he said, patients are responsible for communicating with their care team. Healthcare workers must listen to every patient, or it is not patient-centered care. And so I will leave you with this thought. What if the secret to preventing admissions and readmissions is just as simple as listening to the people we serve? So, questions?
Thank you so much, Michelle and Renita. It sounds like you guys are doing a lot of amazing and wonderful things at Longmont. And we'll go ahead and open up the discussion now for any questions that you all might have for Renita and Michelle. Please feel free to type your questions in the chat box, which is located at the lower left-hand corner of your screen. And to get the ball rolling, Renita and Michelle, I do have a couple of questions for you guys. I was just curious, the continuum team diagram that you put up at the beginning of the presentation was just wonderful. I love to see all the connections. And so I was just curious, what were some of your biggest challenges that you faced in forming that continuum team? And as well, what were any resounding lessons learned?
Well, I would say the biggest challenges were still are is people, the implication that people have that we don't think they're doing a good job. Meaning, well, why do we have this meeting? Why do we all have to be here together? It's one more meeting. Do you not think we're doing a good job? And my answer always to that is, if we didn't need to learn and grow, if we thought our system of healthcare was so good, we wouldn't be in the position we're in right now. Meaning, we did have a problem with readmissions. So yeah, we do need to change our structure in our system. So it's moving away from those mindsets of, this is all the way we've always done it, this is the way, why do you think we need to change things? And that's really an ingrained mindset within the inpatient side of how we deliver care. And, and it's taken some time and movement, and it's, there's been some hurt feelings, and there's been some one-on-one meetings, but honestly, we have a chief nursing officer who really says, no, we will all be meeting together. We will be coordinating care in a better fashion. So having good leadership and not getting our feelings ruffled too much or our feathers ruffled too much has helped us really move that forward.
Great. Okay, thank you. And we have a question from Jeanette Fisher. She says, Longmont is doing amazing work. What do you think health plans can do to support these initiatives and decrease unnecessary hospitalizations?
Well, that is a good question because, we all know that health plans, the insurance industry drives care. It truly drives care. And so, but I still am going to go back, I'm definitely going to go back, Jeanette, to empowering our patients. Because honestly, if these healthcare plans continue to hear from patients who say, I'm working with a system, I love the care I'm receiving. Right now in our integrative medicine center, Medicare and Medicaid don't pay for these integrative medicine services. And I will be honest with you, Longmont is not Boulder. We have a lot of low-income people. We have a lot of need for housing, low-income housing. So therefore you think, how can people, if Medicare and Medicaid don't cover integrative medicine, and that's the population we serve in our integrative medicine center, how do we cover those costs? We get creative, we get innovative, we have community sponsors, we have beautiful programming in place where we've engaged the community to help cover that. We do scholarships. We have one person scholarship another person. We have gotten so creative in over the 23 years that we do this. There is no excuse for our insurance industry to not move with the times and have a culture shift like the rest of us are trying to make happen. It's driven by the patient.
Great, thank you. And another question from Victoria Linden. She says, thank you for this incredible work. How did you get buy-in from the doctors and patients?
Oh, let me tell you there. I got called to the principal's office so many times when we first started this back in 1992 and 93 and 94 because the doctors did not like alternative medicine. They thought it was a bunch of hooey. But again and again, the patients were the one who led this effort. It was from our Patient and Family Advisory Council, which is another point why you want to have them, because it made it really hard for my organization to say, Michelle, we can't do that, when it was a community request. So I think what the doctors saw over time is we weren't taking patients off their medicine. We weren't just taking them off of some antidepressant and putting them on St. John's wort. We weren't doing that. Actually, our nutrition therapists do the same thing with herbs that we need to be doing more with pharmaceuticals. They have the patient bring in all of their herbs and supplements, and we usually take people off a good majority of them and only put them on their top 3. Any good geriatrician will tell you that any elderly patient should only be on 3 medications. So the very viability of integrative medicine is to be used in integration to help control some of the symptoms of the medications that they actually need to be on. So I think where we've won our docs over and how we've got our emergency department doctors support, which by the way I know a couple of them wouldn't mind me saying that they actually come and are frequent patients of our center. We've won them over by having them come here and seeing what we do and getting our hands on them and hiring only the best integrative medicine staff. It takes time, it takes persistence, but Victoria, we're just proof that it can happen, and it is patient-driven.
That's great, thank you. Well, I think that we'll go ahead and wrap up. So thank you so much again, Michelle and Renita. Thank you everyone for joining us today. This was the third webinar in our learning series designed to complement our symposia. Please take a moment to register to join us on Friday, October 16th for the second of 3 symposia to start building and putting community connections in action. Registration is available through our webpage under Events and on the Take Action tab on the right-hand side. We hope it has been a valuable use of your time and hope we see you all in October. This webinar has been recorded and will be available on the HTC website in the next few days. Have a good day, everyone. Thanks again for joining us.